So today we're going to be talking about understanding the opioid crisis. My name is Danielle Voorhees, and I'm the Health and Human Sciences educator for Purdue Extension here in Grant County. This is about a 1-hour presentation and discussion, and at the end of the presentation, there will be a voluntary survey. Okay, so does anybody here know or familiar with Purdue Extension? You can unmute, drop it in the chat. I see a thumbs up. Yeah, awesome. Great. So Purdue Extension has 4 different program areas, which is agriculture and natural resources, community development, health and human sciences, and 4-H youth development. And so basically in a nutshell, Purdue Extension connects university research and expertise to communities regarding those 4 areas. And so basically, we are located on campuses and throughout 92 counties in Indiana. So Purdue Extension, in regards to today's topic, partners with several organizations across the state to address the challenges of the opioid crisis with a role of focusing on prevention education and increasing community understanding about this often misunderstood topic. So I'm going to share today's objectives. This is what we want to cover today. I'll go ahead and put those on the screen here. We're going to talk about defining the terms and concepts related to opioids, opioid misuse, and stigma. We're going to review the opioid crisis in the United States and in Indiana. We're going to name at least 2 steps that you can take in response to the opioid crisis. And we're going to review extension and county resources to learn more about the opioid misuse prevention, treatment, and recovery. And the final takeaway, we want to start changing the way we as a culture think and talk about substance misuse, which includes how we talk about it with our healthcare providers and how we talk about it with our friends, families, coworkers. So first, we want to define some terms to set the scene for this complex and controversial topic. So how many people here today are familiar with opioids? You don't have to explain how specifically you know, but if you drop it in the chat, unmute, raise your hand. How many of you are familiar with opioids?
I am.
I see a couple raised hands, I hear. All righty. Okay, so we do have some who might be a little familiar with it. We're going to go ahead and start by defining opioids. So opioids is a catch-all term for many substances that bind to specific parts in the brain called opioid receptors. A person can consume opioids from opium, which is found in poppy plants, like in the picture here, or from man-made or synthetic versions. But our body also produces small amounts naturally to help manage pain. There are several kinds of opioids that act in slightly different ways. The names are listed here. These are some of the most commonly recognized opioids, but there are many more. So if you can't see the screen here, the common opioid names include oxycodone, hydrocodone, heroin, codeine, morphine, and fentanyl. So let's talk about some reasons why opioids are most often used. Opioids have been used for many purposes throughout human history. Opioids have most commonly been used for physical pain management and or emotional pain management. Today, opioids are prescribed to reduce physical pain. Some examples of common opioid use for physical pain management would be things like chronic pain conditions, after workplace injuries, or after surgery. Opioids are not prescribed for emotional pain management, yet many people also claim short-term emotional pain relief from taking them. How we feel physically affects our emotions and vice versa. This is referred to as the mind-body connection. Sometimes our emotional distress shows up as physical pain too. So I know for me personally, I'll get headaches really bad if I am in emotional distress. Or it can even be my muscles get tense and then I compensate and end up using one over the other and causing myself pain. Some reasons people may use opioids for emotional pain management could include things like depression relief, anxiety relief, or reduced distress after a trauma. These uses can be unintentional or indirect, but can also be misuse. Opioids can therefore affect people in multiple ways. The lines of appropriate opioid use can also become blurry and lead to opioid misuse. How many of you have heard of the term opioid misuse before? I see some hands. Yeah.
Yeah, misuse. Right here.
So the term opioid misuse is an umbrella term to describe several behaviors along a range of risk from mild to severe. Opioid misuse is defined as taking opioids in a way that's other than prescribed. So examples of that would be taking opioids without a prescription or taking a different amount other than prescribed. Opioid misuse can lead to dependence, which is the feeling of being unable to stop, or opioid use disorder, which is a diagnosable health condition. Unidentified or untreated mental health issues may lead people to misuse substances as a way to cope with their issues. The truth is that anyone is at risk for becoming dependent on opioids, even when taken as prescribed. However, not all opioid misuse starts with someone being prescribed opioids, and not all people who take prescribed opioids become dependent. We share this information not to create fear about opioids or to assume that opioids are all bad. There are justified medical reasons to take opioids, and people do the best they can with the tools around them, but there are also risks. Opioid misuse has become a crisis because of the risk to become dependent and the risk to overdose from use, which we see happening at alarming rates. So we're going to talk a little bit about the history of opioid. There have been multiple opioid crises throughout medical history, as opioids have been used for medicine and pain relief for centuries now. Just for today's discussion, we're going to focus on events that happened in the last 20 to 30 years that contributed to the United States opioid crisis. And as you can see on the screen, a timeline, and I'm going to just go over that here really quick. So in the 1990s, the healthcare community determined that pain was undertreated. So in 2001, the healthcare community standards established pain as a fifth area to assess as part of routine healthcare. So the four other vital signs would have been blood pressure, pulse, temperature, and respiratory rate. So pain was that fifth area that was added. By asking patients about pain more routinely, combined with claims that patients could not become dependent on opioids, healthcare providers were strongly urged to prescribe opioids when patients reported pain. So many people built up a tolerance, which means that they would need to take more and more to feel the effects, to those opioids that they started with and ended up becoming dependent. So by around 2010, overdoses, the rates of them increased. In response, the healthcare community ended up putting restrictions on opioid prescription guidelines. So many people who relied on prescriptions could no longer get them and started looking elsewhere to get opioids. So then a market for easily accessible opioids developed, which ended up leading to untested and often unsafe opioids, which also in turn caused overdose rates to spike up. So as previously mentioned, the opioid crisis is such a big issue because of the risks to become dependent or to overdose. Now that we know some of how the current opioid crisis came to be, let's talk about who the opioid crisis affects. So it's not just a rural or city problem, a men or women problem, a young or old problem. It affects all kinds of people. Does anybody have any examples of people who you might think is affected by this crisis? You can drop them in the chat. You can unmute, whatever you're uncomfortable or most comfortable with. That's okay if not. We'll talk about it. So then I will ask this question. Just think for a second about how many opioid overdoses that you think happen in the US every day. So I'll give you a second. Think about it. How many opioid overdoses do you think happen daily in the US? Okay, everybody got their estimate or their guess?
I think about 7.
Good. So opioids are the most commonly misused prescription medications that lead to emergency room visits and overdose deaths. So in 2018, there were 6,740 prescription emergency department visits daily, which is over 2 million a year. And there were 130 prescription overdose deaths daily, which is over 45,000 a year. So not all of the 67,000 nationwide overdose deaths were from opioids or even from prescribed opioids, but 70% from one substance type is very high. So yeah, that's a big alarming statistic here. So transitioning now into risk factors for opioid misuse. There are several factors that can contribute to opioid misuse and developing an opioid use disorder. In addition to the pain issues that we've already discussed, adverse childhood experiences or ACEs, financial difficulties, and limited opportunities for prosperity, chronic pain, and social disconnect are all factors. So ACEs refer to potentially traumatic events that occur in childhood. These experiences undermine a child's sense of safety, stability, and bonding. So a few examples of ACEs would be experiencing violence or abuse, experiencing neglect, witnessing violence in the home or in the community, having a family member attempt or die by suicide, or growing up in a household with substance misuse or instability due to parental separation or a household member being in jail or prison. Some examples of economic or financial difficulties would be food insecurity and limited access to healthcare, which potentially leads to issues with chronic pain. Some examples of chronic pain would be fibromyalgia or repetitive movement injuries. And lastly here, some examples of disconnect and social isolation would be disassociating from friend groups and family during use and abuse, and challenges to engage in social activities due to physical limitations, as well as using substances as a coping mechanism instead of how they're intended to be used. So now that we know the nationwide snapshot, let's look at Indiana's numbers. There is a range, even within different areas of the state, based often on demographics and variation in substance availability. But overall, the number for the overall statistics went up from 2018 to 2019. So as you can see here on the screen, it went from 1,098 deaths in 2018 to 1,211 in 2019. So we've kind of set the scene for the opioid crisis. So now we're going to talk about what can be done about it and what the response looks like. The response to the crisis can be broken down into two parts. First, changes in attitudes and reducing stigma. And second, introducing and expanding support options for prevention, treatment, and recovery. So can I have someone, or all of you, whoever wants to, either drop in the chat or unmute, how would you define stigma? So can someone share with me how you would define stigma? Everyone can be impacted. See that in the chat. Negative stereotypes. Yeah. Okay. Oops. Stigma is when you don't know someone or their history, but make decisions about who they are. Good example, yeah. Thanks for sharing. The way we talk about things often shows our attitudes towards how we feel about them, like some of you have mentioned. And the way people have been talked about around opioid misuse, or OUD, and all the substance use disorders has been very negative most often. This stigma affects whether people get help and whether communities welcome resources and services to address substance misuse. So the definition of stigma can be that people are negatively labeled, stereotyped, and devalued in society, often leading to discrimination. So a few of you did share really good examples of stigma definition. And fewer than half of all individuals living with a diagnosable mental health condition or substance use disorder actually seek treatment. And less than 10% of people who need opioid use disorder treatment actually receive it. So alarming information there. Stigma is especially a barrier among rural communities, individuals of color, youth, men, military professionals, and health professionals. Response support systems and services struggle to take hold if there are fears about how these services will influence the community, if there are negative attitudes about the people who use the services, or if people disagree about whether these services are appropriate. Mental health and substance use disorders are valid health conditions, not personal failings. The words we use to talk about substance use make a difference in how we view people struggling with substances. By thinking of and talking about substance use issues in us versus them terms, we ignore that this is a community-wide, statewide, and nationwide issue, and that we are all affected by the opioid crisis. Reducing stigma starts with you and me. When a person is receiving treatment for cancer, family and friends will often show them support by offering to take them to the doctor's appointments, bring them meals, and offer help in any way that they can. If a person is dealing with substance use disorder and depression, what's the response that they typically receive? Do you treat the person differently? Do you talk to them openly about how you can help? I don't know. Substance use disorder is a disease just like cancer. So individuals who are seeking recovery treatment need our support just as much as our neighbor who is battling cancer. It's important to use person-first language, meaning that we recognize them as an individual first, not by their condition or behavior. This shows valuing the person as a human. This discusses the condition as something a person has, not as a type of person that they are. So instead of saying John is a depressed person, we should say John experiences depression. So we're not labeling John based on his mental health concerns. We are just explaining that this is something that he's experiencing. There are many statements that convey judgment or negative association related to substance misuse. So this chart here on the screen is sharing some examples of stigmatizing phrases and more neutral alternative statements. So we have here, instead of saying addict, user, druggie, junkie, or abuser, we could say person with opioid use disorder. Instead of saying drug habit, we could say disease. Instead of saying ex-addict, we would say person living in recovery. Instead of saying relapse, we could say had a setback. Instead of saying stayed clean, we could say maintained recovery. And instead of saying dirty drug screen, we could say a positive drug screen. So we are actually going to practice this. We are going to change some statements and make them into person-first language. So can somebody either put in a chat or unmute, how can we change this statement where it says Taylor is a former addict into a more neutral statement.
I'm muted.
So I got Taylor is a person living in recovery. Taylor has a history of opioid abuse. Yeah, great examples. So there's no one answer, just like I got a couple examples here. One, Taylor is a person living in recovery, or Taylor has a history of opioid use disorder. Those are both fine ways to say that, but just for the purpose of an example, we did put here that Taylor is a person in recovery. Good job. Next one, we have Charlie is a drug abuser. So what could we say instead? How could we change this sentence to make it person first? Okay, I got Charlie is a person with opioid use disorder. Charlie struggles with an opioid addiction. Yeah, great examples. So Charlie is a person with substance use disorder. This, again, we're taking the label or the negative descriptors and changing them into just a part of Charlie's experiences. And we're not labeling Charlie with the negative statements. And I think this is the last one here. So how could we change this statement? It says, Morgan had a dirty drug screen. Okay, got some in the chat here. Yeah, so we could say instead that Morgan's substance screen came back positive, had a positive drug screen. Awesome. So I want you to think about some language cues that you can listen for and changes that you can make to reduce stigma. It's not something that happens overnight. We shouldn't expect ourselves to be perfect immediately. It does take practice. So just try and pick up on those language cues and those changes that you can make to reduce the stigma, especially when engaging in conversation with people that you know. So as mentioned, part one of the opioid crisis response is about changing stigma, and part two is to introduce and expand support options. This can be approached from three angles: prevention, treatment, and recovery. And we will talk a little bit about each one. So what we mean by prevention is having education about the risks, knowing the tools available to reduce chances that someone will develop opioid use disorder, and or to prevent opioid overdose. It's much easier to prevent a hole in a boat than to treat it when it's already leaking and sinking. Also, understanding behaviors and risk factors that we talked about earlier, like those ACEs or injuries. And lastly, here on the screen we have harm reduction, and this refers to a spectrum of strategies and ideas aimed at reducing the negative consequences associated with drug use. So some examples that prevent overdose deaths and spread of disease include administering naloxone or Narcan in an emergency to prevent overdose death. And another example would be needle exchange programs. So just to give you an idea of harm reduction that's in our society other than these two would just be things like speed limits, seat belts, sunscreen, condoms, things like that. Those are all considered harm reduction. And now we're going to talk about treatment. So many levels of treatment exist to help people keep people safe and alive. And there's no one right form of treatment that works best for everyone. Some examples include short-term rehabilitation treatment, group peer-led meetings like Alcoholics Anonymous, medication-assisted treatment, and many more. As stated here, the best treatments provide a combination to meet an individual's specific needs. So everybody's different. There's no one best practice or one best answer. And you can see here on this screen some of the examples. And moving on to recovery. So the thing with recovery is many people assume that once a person goes through treatment, everything is done and there's no more concern. But just like when a person has surgery and stays in the hospital briefly, it's usually followed by extended recovery outside of the hospital. Substance recovery is more than just substance abstinence. It's an ongoing process long after treatment ends. Recovery is a process of change through which people improve their health and wellness, live self-directed lives, and strive to reach their full potential. There are 4 major dimensions that support recovery, and you can see those here listed on the screen. The first one is health, which is overcoming or managing one's disease or symptoms and making informed, healthy choices that support physical and emotional well-being. The second one listed here is home. This is having a stable and safe place to live. The third one here is purpose, and that's just conducting meaningful daily activities and having the independence, the income, and the resources to participate in society. And lastly, listed here on the screen is community, and this is really having those relationships and social networks that provide support, friendship, love, and hope. So you may now wonder, okay, what can I do about all this? So we're going to talk about some ways to take action. So first we're going to have you, I'll list those here on the screen, there we go. Go to trusted sources for education and information about what's happening in your community. Again, just like earlier, changing language takes practice. So we're going to work on changing stigmatizing language use. Monitor your prescriptions and keep them secure when you do have them. And you can find out where your community stands on naloxone administration and needle exchange programs. Does anybody have any other examples that are not listed here? This is not an extensive list by any means, but does anybody have any other ways that you can think of to take action? Okay, I don't see any. I did get one in the chat. Put yourself out there to gain knowledge from those in recovery. Yeah, that's a great example. Great example. So if you want to learn more, we will provide you with some suggestions of where to start. There is a resource packet that I will send out to everybody, and it includes Purdue Extension specific resources, other education and prevention resources, mental health resources, and statewide resources. When used correctly, opioids are useful and necessary. Opioids themselves are not the problem, but the misuse or abuse of them is really the problem that we're focusing on here. We do not want to make people feel bad for seeking pain relief, and we know that not all prescribed opioid situations are the same. And if you have concerns about your prescribed opioids, talk to your health provider, discuss your concerns and fears, and don't be afraid to ask questions. So I do have Kelly Hostetler from Marion General Hospital here, who is going to share a little bit about the core program here in Grant County. So Kelly, if you want to go ahead and unmute, the floor is yours.
Actually, Pam and I are here today, but she's
okay, awesome. So we've got Pam and Kelly.
Right. My laptop decided not to work. We do want to share about a little over a year ago, Marion General received a really large grant from HRSA to address substance use disorder and opioid use disorder. And of that, actually, there were a couple grants prior to that that helped us in the planning. We have created a consortium, and we're always happy to add more people to the consortium. We have about 14 members. Our original partners were Marion General, Grant Blackford, the Sheriff's Department, and Bridges to Health. And we've added many since then, all the way from the Justice Partners to the Community Foundation to Family Services, on and on. I can provide that whole list if someone needs that. But we have hired 4 peer support specialists who are all in recovery. And right now they are virtually on call, except in the late night hours, they are on call pretty much 7 days a week. And our emergency department, when anyone comes in with substance use issues, we'll call them and they'll actually come and meet with them at the hospital, or if they've been admitted, they will also come and meet with them. They are open for referrals from the community. The number for people to call for it is, I'm trying to remember here, it is 765-231-2111. That will connect people with a peer support specialist. So they are willing to kind of walk the journey with people, because the peer support would tell us until somebody is ready to quit, there really isn't anything anybody can do, but they want to create a relationship. So let's say someone comes to the emergency department and they're not ready to quit, but they have young children, they're struggling with childcare or different issues. The peer support can help them find those resources and keep connected to them, so that when they're ready to quit, they'll share their stories. They'll share their stories to organizations. So if any of your organizations or churches or anybody would love to have a peer support, they do a great job of sharing their story. Then we also, through this program, have hired community health workers, and that's 2 people, and their focus is really working on helping people find healthy resources that are involved in substance use or even in recovery. Because as you know, especially people coming out of active addiction really have not taken care of their health at all because that has been overridden by their other desires. We also are working on getting more and more churches involved. We were kind of getting off to a good start right before COVID. Several churches have been were holding pro-social events where there is no alcohol, and obviously drug-free. Some opened their gyms, some of them had a canvas painting night, others had like a bonfire time so they could bring their families. So we're working on a retreat for the recovery houses this fall, just to let them get away for a weekend and have a good time. So we have a lot of initiatives. We do have some harm reduction initiatives right now. We're getting ready to start free Narcan to anybody in the community. There's like, what is it, 4 or 5 minute training, maybe 3 minutes. So I do want to mention, for those of you who are interested, the recovery groups, the recovery community runs their own meeting every Friday at God's house at 6 o'clock. And their people share their stories. They have a worship time. And September 18th, our team will be there training and handing out free Narcan to all of those people. And if your agency would like free Narcan and training around that, we have it free. So we would be happy to help with that. You can, Danielle has our emails. You can email her for if you want to be, or if you have family members that are struggling with substance use disorder. We would encourage people to have Narcan. This is the nasal Narcan, not the injectable. Most people in the community were not real thrilled about the injectable. So we do have that. And what else should we talk about, Pam?
I think that's good.
Okay, so we have a lot moving forward, and we're always happy to bring on more partners or more opportunities for education and outreach. We work a little bit with, we have actually a pretty cool project going on right now with Taylor University, one of their classes for a drug take back program, and they're wanting to help us with some of our information and marketing to get out about CORE. If you have seen some of our billboards with the chains and the hands up around town to advertise CORE. So we'd be happy to share more information and bring more partners on.
Awesome. Anybody have any questions for Kelly and Pam about CORE? And like she said, like Kelly said, you can either reach out to me and I can connect you, or I can, yeah, Kelly, if you want to drop your email in the chat for people, that would work too. So thank you, Kelly and Pam, for sharing about CORE. And like I said, if you have any questions, you can reach out to either of us. And CORE is listed on the community resource guide that you guys will all receive at following the program today. There is a video that I do want to share. Let me stop sharing this first and see if I can't pull it up here. Okay. I always laugh because I see like memes and things about the Zoom sharing, like, can everybody share my screen? Everybody's saying the same thing every time. But that's our reality right now. Okay, so let me share let me share this screen and get this going. Okay.
Susan. Susan loves to bike. While out for a ride, she falls and breaks her arm. Special cells called neurons send a signal through the spinal cord to the brain, which interprets the signal as pain. Susan understands the pain means she needs to go to the hospital, and her body is equipped for survival, helping her not to panic so she can seek help. Many of her neurons are covered in proteins called opioid receptors. These receptors act like a brake to slow down the neuron's ability to send pain signals. When injured, her body releases natural painkillers called endorphins. Like a key in a lock, endorphins activate opioid receptors, slowing down the pain signal and preventing a panic. Susan gets treated for the broken bone, but 3 months later, her arm still hurts. And now that pain is making her feel depressed and anxious. So her doctor prescribes an opioid painkiller. There are many different opioids, but they all share a chemical similarity to our own endorphins. This allows them to bind to the same opioid receptors and stop pain signals. But that's not all they do. Deep inside Susan's brain is a region called the ventral tegmental area, or VTA for short. The VTA is full of neurons that produce a chemical called dopamine. When something good happens, dopamine is released, giving Susan a feeling of pleasure. This helps teach her brain to keep seeking out good things. To keep dopamine neurons in check, inhibitory neurons keep the brakes on until something good comes along. Just like the pain neuron, these neurons are covered in opioid receptors. When Susan takes the painkiller prescribed by her doctor, the opioid receptors turn off the inhibitory neurons and release the brake on the dopamine neurons. The rush of dopamine temporarily eliminates Susan's depression and anxiety, and she feels relief, calmness, and even euphoria. As Susan continues to take the painkillers, her brain responds by trying to regain its balance. Her inhibitory neurons work extra hard, even when the opioid receptors are activated, and it becomes harder and harder for her dopamine neurons to release dopamine. Susan finds that she needs to increase her dose of painkillers in order to feel comfortable. This is called tolerance. Eventually, Susan's pills run out. Inhibitory neurons that had been working overtime were let loose, clamping down on those dopamine neurons and shutting them off almost completely. Now, not only is Susan in pain, but the depression and anxiety come back. On top of that, Susan feels ravaged by an inescapable physical sickness far worse than any flu. Susan's body is going through withdrawal. Most people who take opioids for a long time tend to experience some withdrawal, but they can still stop taking the pills and return to normal. But for people like Susan, it's not so easy. Her genetics and the environment she grew up in put her at a higher risk for addiction. Her withdrawal symptoms aren't just unpleasant, they're unbearable. Susan thinks the only way to feel normal is to find more opioids. And this is how the cycle of opioid addiction emerges, driven by a brain trying to regain its balance. But there is hope for Susan. Though the road to recovery can be challenging and there may be setbacks, treatment can retrain Susan's brain. With the help of medication and therapy, Susan finds pleasure in her life once again.
Okay. So that was just a little video explaining some of the process going through the brain. I'm going to share my PowerPoint again. And okay. Whoops. There we go. So these are some of the points that I'm going to put up here that we really want to drive home from today's presentation. And that includes that the opioid crisis is ongoing and Indiana is above the national average. That we must reduce stigma about substance misuse and seeking treatment. Prevention happens through education. And treatment is not a one-size-fits-all. Recovery is a process of change, and anyone is at risk, everyone is affected, and anyone can help. So if anybody has any questions, feel free to ask. I am going to share in the chat the link to the survey. Let me stop this share for a second so I can drop that in the chat. But this survey is voluntary. You are not required to take this survey. This just helps get some feedback on how you felt about the program overall and how well we are doing and how we can improve. Oops, I just copied the, I will copy, this is the link to that, oops, I didn't send that to everybody. The link to the video, if anybody's interested in watching that again or sharing that. And this is the link to, in the phone number, if you want to text and do your survey, you can do that. But there's also a link here where you can just click on it and it should pull up the survey for you to be able to take it. And I will put, share my screen again so you can see it largely. And again, if anybody has any questions at all, feel free to ask. If you think of it later, go ahead and send me an email or call our office. I'll be happy to chat. Otherwise, I'll hang out here for a couple minutes. And if anybody thinks of anything, but otherwise, that's all I have for you today. And if you think of any questions, send me an email. And thanks for joining today.
You have a question, Misty?
No.
Okay. I didn't know.
I was up to go smoke.
Okay. Well, thank you very much.
Thanks, Laura. Thanks, everybody.
Greg know all about opiates.
Oh, girl.
All about withdrawals.
She's
laughing at you. The overdose.
Yeah, she is.